Okay, all right. So, hello again. So, this is section E. All right, we'll talk about section E, part 4, section E, substance related and addictive disorders. So, here we're going to talk about reward, craving, loss of control, and the psychology of addiction. So, we now move into section E, again, substance related and addictive disorders. Now, this section is important because addiction is one of the most judged and oversimplified topics in mental health. A lot of people still think addiction is just about bad choices, weak discipline, or lack of self control, but clinically it is more complicated than that. These disorders involve reward, reinforcement, craving, tolerance, withdrawal, relapse, and loss of control. In other words, they affect not only behavior but also motivation, brain processes, coping patterns, relationships, and daily functioning. This is also one of the areas where students need to think carefully because not all substance use is a disorder, but not all normal use is harmless either. So the real question is not just does the person use a substance? The deeper question is what kind of pattern is developing around the use. And that takes us directly to the next slide. When does a substance use problem become clinically significant? What makes a substance use problem clinically significant? So, a substance use problem becomes clinically significant when it starts producing distress, impairment, risky behavior, repeated failed attempts to cut down, relationship strain, role failure, tolerance, withdrawal, or harmful consequences. The important point here is that frequency alone is not enough. A person can drink occasionally and not have a disorder. Another person may not even use daily, but the pattern may still be clinically dangerous because it leads to impaired judgment, risky decisions, conflict, or loss of control. So, in abnormal psychology, we do not just ask, how often does the person use? We also ask, what is the cost of that use? What happens because of it? What happens when they try to stop? For example, if a student says, I only drink on weekends, that tells us very little by itself. If every weekend ends in blackout drinking, missed responsibilities, risky behavior, and regret, then the pattern matters more than the schedule. So the key idea here is this. The issue is not just use, but the combination of loss of control and harmful consequences. And that leads us to an important distinction. Use, misuse, and disorder are not the same thing. Substance use exists on a continuum. At one end is use, which does not automatically mean pathology. In the middle is misuse, where the pattern becomes harmful, risky, or maladaptive. And further along is substance use disorder, where the pattern becomes more severe, more impairing, and harder to control. This distinction matters because not every use pattern is automatically disordered, but it is also a mistake to assume that if a person is still functioning in some areas, then there is no clinical problem. Many problems develop gradually. Substance use disorder involves a broader pattern that may include impaired control, social or occupational disruption, risky use, tolerance, and withdrawal. It can also be mild, moderate, or severe, which reminds us that this is not an all or nothing category. A relatable example would be this. One student drinks socially once in a while and stays in control. Another starts using alcohol or another substance to cope, cannot reliably stop when they intend to, and begins building their routine around it. Same substance, very different clinical meaning. So once we understand the continuum, the next question is, what are the core features we usually look for in a substance use disorder? So the core features of substance use disorders often include, number one, craving, impaired control, second, Third, continued use despite harm. You know that it's already harmful to you, but you're having a hard time discontinuing it. Tolerance, withdrawal, and repeated relapse. Now, let's unpack that. Craving means the person strongly wants the substance. Impaired control means they use more than intended, use longer than intended, or keep using even when they planned to stop. Continued use despite harm means the substance is already causing problems, but the pattern continues anyway. Then we have tolerance, where more of the substance is needed to get the same effect, and withdrawal, where reducing or stopping use produces distressing symptoms. And then finally, relapse reminds us that even when a person genuinely wants to quit, the pattern can return. One of the most important things to understand here is that substance use disorder is not only about pleasure. Over time, the substance may stop being mainly about enjoyment and start becoming about relief, compulsion, or avoiding discomfort. That is why people sometimes say, if it is ruining their life, why don't they just stop? Clinically, that question sounds simple, but the psychology underneath it is not. All right? Which brings us to the brain's reward system. There you go. To understand addiction, we need to understand reward and reinforcement. Addictive substances affect the brain's reward system, especially pathways involved in pleasure, motivation, and learning. At first, the substance may feel rewarding because it creates pleasure, relaxation, energy, confidence, numbness, or relief. That effect reinforces the behavior, which makes the person more likely to do it again. In simple terms, the brain starts learning, this works, let's do it again. Over time, however, the pattern often shifts. The person may use less for pleasure and more to avoid feeling bad, to avoid withdrawal, emotional pain, tension, emptiness, or stress. So what began as reward can become compulsion. A very relatable version of reinforcement, even outside substances, is this. If something gives quick relief, people repeat it. That is human. The problem with addiction is that the short-term relief can quietly build a long-term trap. So the most important point here is that addiction is shaped by learning, reinforcement, and brain reward processes, not just by poor choices. And two of the biggest reasons quitting becomes difficult are tolerance and withdrawal. Now, let's talk about tolerance. It means the person needs more of the substance to get the same effect, or gets less effect from the same amount. In other words, the body and brain adapt. Okay, it's similar to when you take medication. Okay, particularly psychotropic medications or the ones prescribed by your psychiatrist. All right. So this is very common, tolerance. Now, withdrawal refers to the physical or psychological symptoms that show up when the person reduces or stops using the substance. Depending on the substance, withdrawal may involve anxiety, irritability, sweating, shaking, sleep problems, nausea, low mood, agitation, cravings, or more serious complications. These two processes are very important because they help explain why quitting is often harder than outsiders think. From the outside, people may just say, just stop. But if the body has adapted and stopping creates real distress, the situation is much more complicated than simple advice can solve. This is why addiction can become such a powerful cycle. The person may no longer even be chasing the original high. They may be trying to avoid the crash, the discomfort, or the withdrawal. That is a very different psychological position. And once we understand that, we are ready for the next question. Why addiction is not just a willpower problem. One of the biggest mistakes people make when talking about addiction is reducing it to willpower. The thinking goes something like this. If the person really cared enough, really tried hard enough, or really wanted to stop, they would just stop. That sounds neat, but clinically it is much too simplistic. Addiction involves the interaction of brain processes, reinforcement, coping, stress, learning history, environment, and behavior. So, yes, personal responsibility matters, but responsibility alone does not explain why a person can sincerely want to stop and still keep returning to the substance. So, think about it this way: if the substance has become the person's fastest route to relief, numbness, confidence, sleep, energy, or emotional escape, then stopping means losing not just the substance but also a coping tool. An unhealthy one. Yes, but still a coping tool. That is why recovery often requires building new ways to regulate distress and not just removing the old one. So the key point here is this: addiction is not simply a discipline problem, it is a disorder involving reinforcement, dependence, and impaired control. And alcohol is one of the clearest examples of how a socially accepted substance can still become clinically serious. Let's talk about alcohol use disorder. Alcohol use disorder involves a problematic pattern of alcohol use that leads to distress or impairment. This can include drinking more than intended, being being unable to cut down, craving alcohol, failing to meet responsibilities, using alcohol in risky situations, developing tolerance, or experiencing withdrawal. What makes alcohol especially tricky is that it is socially normalized in many settings. It is common at parties, celebrations, gatherings, and coping rituals. That means problematic use can hide in plain sight because people often assume that if everyone else is doing it, it must be fine. A student example might be someone who says, I only drink socially, but every social drinking event ends in blackout drinking, missed commitments, emotional fallout, risky choices, or needing alcohol to manage stress. At that point, the phrase socially is not doing much clinical work. So the important idea here is that social acceptance does not protect a substance from becoming disorder. Alcohol can be culturally normal and clinically dangerous at the same time, and alcohol is only one part of the picture because other commonly misused substances bring different patterns and risks. All right. Now, let's talk about different substances, all right, like cannabis and other commonly misused substances. So, different substances affect the brain and behavior in different ways, but many can become part of a maladaptive pattern of use. Commonly misused substances include cannabis, stimulants, opioids, sedatives, hallucinogens, and inhalants. Okay, this matters because students sometimes think about addiction too generally, as if all substances work the same way. They do not. A stimulant pattern looks different from a sedative pattern. Cannabis-related problems may look different from opioid-related problems. The effects, risks, withdrawal patterns, and functional consequences can vary significantly. That is why clinicians pay attention to the specific substance, the pattern of use, the context, and the consequences. For example, one student may misuse stimulants to stay awake and keep up academically. Another may rely on cannabis to quiet anxiety or escape stress. Different substances, different functions, different clinical stories. So, the key point is this: substance-related disorders are not one generic category. Substance matters, and so does the role it plays in the person's life. And some substances carry especially high risks for dependence and medical danger, which brings us to opioids and sedatives. Now let's talk about opioids, sedatives, and high-risk dependence. Okay. Some substances carry especially high risks for dependence, overdose, severe withdrawal, and medical complications. Two major examples are opioids and sedatives. These substances are important clinically because the cycle of use can become dangerous very quickly. Opioids may begin with pain relief and then shift into dependence. Sedatives may begin as a way to sleep, calm down, or take the edge off, but repeated reliance can build tolerance and increase risk. One reason these substances are so serious is that they can create a strong pattern of physiological adaptation. That means the body is no longer just reacting to the substance, it begins reorganizing around it. And once that happens, reducing or stopping use can bring intense distress and serious complications. So the big point here is that addiction can shift from choice to dependence more quickly than people expect, especially with high-risk substances. And not all addictions involve chemicals. Some involve behaviors that activate similar patterns of reward and loss of control. So now let's talk about behavioral addictions, gambling disorder, and the logic of compulsive reward seeking. Now again, not all addictions involve substances. Behavioral addiction, especially gambling disorder, show that a person can become trapped in a cycle of reward, craving, loss of control, and repeated harmful behavior even without putting a chemical into the body. The core pattern is still familiar. The behavior becomes rewarding, emotionally gripping, and hard to stop. The person keeps going despite losses, harm, or repeated promises to stop. In gambling, there is also the powerful illusion that the next round will fix everything. That is a psychologically dangerous belief. This matters because it reminds us that addiction is not just about the substance itself. It is also about reinforcement, anticipation, intermittent reward, and impaired control. The brain learns from reward patterns, whether the reward comes from alcohol, drugs, or gambling. And honestly, this is also why some behaviors become so sticky in everyday life. The combination of anticipation, uncertainty, and reward can be very powerful. The issue becomes clinical when the pattern becomes compulsive, harmful, and difficult to interrupt. That brings us directly to the broader cycle of addiction and relapse. So now let's talk about the cycle of addiction and relapse. Addiction often follows a repeating cycle. Trigger, craving, use, temporary relief, or reward. Again, this is the repeating cycle. Trigger, craving, use, temporary relief, or reward. Then there's consequence, guilt or distress, and then renewed vulnerability. Let's walk through that. A trigger appears stress, loneliness, boredom, conflict, right? A cue, a place, a feeling, a memory. Then craving rises. The person uses the substance or engages in the addictive behavior. There is temporary relief, reward, numbness, or escape. After that come the consequences: physical, emotional, academic, social, financial, or relational. Then guilt, shame, or distress may increase, which ironically creates the conditions for the next trigger, and the cycle repeats. This is why relapse is so common. It does not automatically mean the person is hopeless or that treatment has failed. Often, it means the cycle is strong, the vulnerabilities are still active, or the person has not yet developed enough alternative strategies to manage triggers. So the key point here is this: addiction is often cyclical. It is not linear. Recovery is rarely one clean decision followed by permanent success. More often, it is a process of interruption, relapse prevention, rebuilding, and learning. So, once we understand that cycle, the next question becomes, what makes some people more vulnerable than others? Okay, so the key point here is that addiction is often cyclical and not linear. All right. All right. Okay. Let's go to the next one. Okay. Comorbidity in addiction. Okay, addictive disorders often occur alongside other psychological conditions such as depression, anxiety, trauma-related disorders, bipolar disorder, and personality pathology. And this is what we mean by comorbidity. Why does this happen so often? One major reason is that substances are sometimes used as a coping strategy. A person may drink to reduce anxiety, use cannabis to quiet emotional distress, misuse stimulants to push through exhaustion, or rely on substances to numb trauma-related pain. The problem is that the relief is usually temporary. The underlying issue stays, and over time, the substance use adds a second problem on top of the first, and it piles up on and on and on and on. So instead of treating the pain, the person ends up with pain plus dependence. That is why treatment often fails when clinicians focus only on the substance and ignore the rest of the picture. If the addiction is serving a psychological function, that function has to be understood. And to understand it properly, assessment has to be more than superficial. So, let's go now to assessment and differential diagnosis. Assessment in addiction should look at the pattern of use, level of control, craving, consequences, tolerance, withdrawal, motivation, context, and co-occurring conditions. In other words, the clinician is not just asking, do you use? They are asking, how does the use function in this person's life? And this is where differential diagnosis also matters. We may need to distinguish substance-related problems from medical conditions, medication effects, primary psychotic or mood disorders, and non-pathological use patterns. Sometimes the substance is the main problem. Sometimes it is part of a larger picture. For example, if someone is highly energized, sleeping very little, and acting impulsively, we have to ask, is this substance related, bipolar, both, or something else? If someone is paranoid or hallucinating, is that primary psychosis, substance-induced, or medically related? So the key point here is that accurate assessment requires pattern recognition, context, and careful exclusion, and not just quick assumptions. Now, let's talk about stigma, judgment, and clinical understanding. Substance-related and addictive disorders are among the most stigmatized conditions in mental health. People are often seen as weak, irresponsible, immoral, or simply lacking discipline. But clinical psychology takes a different view. It recognizes that addiction involves behavior, biology, learning reinforcement, environment, and suffering. That does not erase responsibility, but it does mean we need a more accurate and humane way of understanding the problem. Stigma matters because it can stop people from seeking help. If a person expects to be judged, shamed, or treated like a failure, they are more likely to hide the problem and delay intervention. And the longer the pattern continues, the harder it may become to interrupt. So one of the most important things this section teaches is this. Clinical understanding is not the same as excusing the behavior, but it is absolutely different from simply condemning the person. So let's recap what we have learned so far in section E. So this recap brings together the whole section. Substance-related and addictive disorders involve patterns of craving, impaired control, reinforcement, tolerance, withdrawal, relapse, and functional disruption. These disorders are not well explained by one-factor theories or by moral judgment alone. The strongest way to understand them is through an integrative model that includes biology, learning, coping, stress, environment, and comorbidity. In other words, addiction is both behavioral and clinical, both psychological and physiological, both personal and contextual. So if you remember one big idea from this section, let it be this. Addiction is not just about using a substance or repeating a behavior. It is about the pattern of control, consequence, reinforcement, and suffering that grows around it. And with that in mind, we are ready to move into the next cluster, right? So section F, feeding and eating disorders. But before we go to section F, feeding and eating disorders, we will pause and I will upload the next part of the lecture series in abnormal psychology. Thank you so much for listening. Until next time.